Welcome everybody to Pediatric Grand Rounds. Before we get started, I just wanted to give a few introductory comments. Sandrain and I were deliberating this week whether to hold Grand Rounds as usual today, given everything that's been going on in our nation this last couple of weeks. And we ultimately decided that it's important, especially now, to continue with our education mission. But we would also like to acknowledge the current social unrest and the call for justice that have dominated our discourse in the past couple of weeks. And so before we launch into Grand Rounds, I've asked Dr. Marcia Treadwell to take a few minutes to provide some brief comments and perspective, and she's graciously agreed to do so. Dr. Treadwell is professor of psychiatry and pediatrics here at UCSF, and she also co-chairs the Benioff Children's Hospital Diversity, Equity, and Inclusion Committee. Dr. Treadwell, please.
Thank you. Thank you for having me. The words that I want to give to our community here is that I think it's important for us to really create this moment as a watershed moment in our history. We as African Americans feel this moment deeply as a convergence of all of the racial violence, police brutality, health disparities, wealth gap, and lack of access to education that's been our existence for over 400 years. But if we make this moment different as a time in our society when we actually take decisive action to end these injustices, then that's heartening. It's been heartening to see the demonstrations all over the world expressing the outrage at the murder of George Floyd as one Black man among many in a long stream who has been murdered in this country in an act of racist violence. But racist violence is not the only thing killing African Americans. In Oakland, where I am, the infant mortality rate for African Americans is 6 times higher than for whites. We have the lowest life expectancy of any group. In San Francisco, wealth is important to health, and the median white household income is $111,000 compared with $28,000 for Blacks, African Americans. In San Francisco, the life expectancy at birth of a Black man is 12 years less than the overall median. So dealing with these public health issues requires faculty, staff, and trainees here at UCSF to go inside of ourselves and see that we have to do better on an individual level at the same time that we're trying to address the healthcare disparities. We have to create an institution where everyone has equal opportunity to advance within UCSF, where the African American social worker is just as likely as the white one to receive praise for a job well done, and where every employee has the tools to deal with microaggressions as they come up. My hope for us as a UCSF community is that we will take this decisive action to achieve those goals.
Thank you, Dr. Treadwell. I really appreciate your comments, and we have so much more work to do to create the type of society we'd all like to live in. So thank you very much. Let me turn it over to Sandrain now to introduce our Grand Round speaker.
Hello, everybody. And I also am going to add my thanks to Dr. Hirsch. Marcia, at very last moment, agreed to come and say a few words. And I think we're all very cognizant of all the work that we have to do and the learning that we have to do and are committed to that. At the same time, I'm also very grateful to Dr. William Bernal for being here today with us. He actually was one of the first people that we canceled Grand Rounds on when COVID-19 first rolled out, and we had not enough time yet to figure out what to do with Zoom and webinars and things like that. And I'm very grateful that he was flexible and wanted to accommodate us in rescheduling for today. Dr. William Dr. William Bernal is a pediatric rheumatologist at UCSF. He did his residency training at the Children's Hospital of Los Angeles, followed by a pediatric rheumatology fellowship at CHOP. He first joined the faculty there, but we were very lucky to recruit him to UCSF in 2013, where he's been on the pediatric rheumatology faculty ever since. He is the co-director of the IP3 program, the pain and palliative care, pediatric pain and palliative care program at UCSF, and the director of the Pediatric Amplified Pain Rehabilitation Program, which actually is abbreviated to PAPR, which has absolutely nothing to do with the PAPRs that we in the ICU have become very familiar with due to COVID-19. So I had to do a double take when I saw that abbreviation, but it's Pediatric Amplified Pain Rehabilitation Program, and that's the focus of his talk. He tells us that he became interested in pediatric amplified pain syndromes during his fellowship in pediatric rheumatology. His experience in pain clinic and rehab program was focused on treating pediatric amplified pain syndromes, and he developed a passion for continuing this work and building a program here at UCSF, and that's the program he currently directs. It's a very intensive inpatient program consisting of physical therapy, occupational therapy, creative arts therapy, and psychotherapy to restore function in patients. And as a clinician, half of his work is focused on better living through biological medications for autoimmune diseases, but the other part is really helping patients restore function by treating their pain. And he's going to talk about this for the rest of this hour. Dr. Bernal, without further ado, I invite you to take it from here.
Thank you. Okay, hopefully everybody can see my screen. Should see the title slide.
Yes, we can.
Wonderful. So thank you, Sandrine, for that introduction and for the invitation to speak to you all today. And thank you, Dr. Treadwell, for joining us, and Dr. Hirsch as well. I'll start off by saying that Sandrine rightly noted the acronym for our Pediatric Amplified Pain Rehabilitation Program, which I have for 5 years now. I've been correcting people as paper instead of PAPR, and I couldn't have predicted the pandemic. But I will say that maybe we'll need to do some change in marketing from here on out, because it's going to be quite an uphill battle for me to be correcting people constantly about PAPR versus paper. But I'm excited to speak with you all today about how we go about treating pediatric amplified pain syndromes across the spectrum from outpatient to inpatient therapies. And I have no relevant disclosures for today. And our objectives today are to learn a functional approach to managing disability due to chronic pain in children and adolescents, and to appreciate stressors as triggers and perpetuators of amplified pain syndromes, and to learn the rationale and evidence for treating amplified pain syndromes using pain rehabilitation. And we can start with a question of what is pain? Let's first define what it is so that we can define what we're talking about. And if we look at a classic IASP text, pain is defined as the subjective expression of an unpleasant sensation or emotional experience associated with actual or perceived tissue damage. And we can start with our first patient of the day. And these patients are going to exemplify a couple of factors. One, that pain is subjective, and two, that there's always an emotional experience with it, and all the more so in the chronic pain setting. Our first patient of the day is a 17-year-old female with chronic widespread pain. She's previously active in high school basketball and volleyball, and comes to clinic noting pain for several months of hurting basically all over. And she's also had some non-restorative sleep, which has led to chronic fatigue symptoms. But looking back in the previous year, she was actually diagnosed with chronic abdominal pain and worked up extensively, but not found to have a specific diagnosis. She was also found to have depression and was medicated for depression with some improvement in her depressive symptoms. She underwent a cholecystectomy after finding sludging in her gallbladder And unfortunately, this did not relieve her abdominal pain. And then later developed chronic widespread pain, for which she presented in our clinic. Over time, her GI function continued to deteriorate, and she ended up requiring TPN for nutrition, which she really received via central line. And subsequent studies showed normal gut manometry, and she was found to have her gut issues attributed to being secondary to chronic pain. She was referred to an adult gastroenterologist for consideration for placement of a gastric pacer, but it was ultimately not thought to be a candidate for this procedure. And we're going to return to this patient a little later in the talk, but she already has some features of chronic pain and pain that is not just musculoskeletal, but also abdominal GI as well. Our second patient of the day is a 13-year-old female. She's an avid cross-country runner, and she has this history of multiple ankle sprains, with each one taking longer for her to recover from up until her most recent episode, of which she still hasn't recovered. And you can see some crutches leaning in the back of this photo, and she came in on crutches. And you can also see this white sock on her right foot, because she can't even tolerate the sensation of a moccasin on her foot. And when I ask her to remove that sock, we can see this purplish, dusky colored right foot with some muscle atrophy of her right calf. And you can also note that her pant leg is rolled up to above her right knee, because she has pain even with the sensation of the denim over the skin in that area. And we're going to return to this patient a little bit later in the talk as well. Now, how do we go about diagnosing amplified pain syndromes? We can first define some more terms, and we can look at physical exam signs of pain amplification. And the first is allodynia, which is pain due to a stimulus that should not normally provoke pain. This can be light touch, mild pressure, a slight pinch that should not normally be painful, versus hyperalgesia, which is an increased response to a stimulus that is normally painful. So more pain than expected with a painful stimulus, such as a pinprick. And when both of these findings are present, we term these hyperesthesia. And these are helpful signs of pain amplification in patients. Now, features of children with amplified pain. On history, we tend to hear that there's pain lasting longer than expected for injury. There's pain out of proportion to the inciting injury, if there is one present. And there's pain that gets worse with rest instead of better, worse with immobility instead of better. And with the person in front of us, we see a disproportionate loss of function, which is ironic given the parents often report that their child is actually the one that's historically had a high pain threshold and is now reporting quite severe chronic pain. By and large, testing will be normal or will show resolution of a previous injury that has since healed. And with probing, we may find some preceding major life stressors. We'll talk more about that in a bit. Now, in physical exam, the patient in front of us might be calmly reporting a very high level of pain, 8, 9, 10 out of 10 pain with an incongruent affect. And although they may have difficulty moving in parts of the body that cause them pain, such as an arm or a leg, with distraction, you might see more spontaneous movement of this limb, which shouldn't make one think necessarily that this is factitious pain, but can really point to the importance of attention when it comes to dealing with this pain. We will often see allodynia or light touch pain with variable borders and that don't fit with dermatomes. And patients over time can actually become hypervigilant, where they have one part of their body that is not functioning correctly. They have a chronic pain without a clear diagnosis or cause, and they naturally become vigilant to other symptoms that can be occurring in their body. And over time, they develop kinesiophobia, or fear of movement, which is reasonable given the severity and chronicity of their pain. So amplified pain syndromes can come in diffuse forms, such as fibromyalgia, or localized forms, such as complex regional pain syndrome. And terminology can be contentious. We could have a whole nother 60-minute talk on chronic pain terminology in pediatric settings. And in the research field in general, there's a sharper distinction between more diffuse pain syndromes and more localized ones. But clinically, what we see is that patients can move along a spectrum of really beginning with first localized pain, and then over time, has been shown in adults and kids for quite some time, they can actually progress to having more diffuse pain and more areas of pain involved. But most importantly, I think the diagnosis should be something that guides therapy, that provides information to patients and parents as they're on this journey of treating their chronic pain. And looking at diagnostic criteria, in 1990, the American College of Rheumatology published diagnostic criteria for fibromyalgia that required noting number of tender points that were positive on a physical exam. And you can see on the figure to the right, the location of these particular tender points. And some 20 years later, they moved away from tender points and looked more towards just noting the extent of widespread pain in terms of areas of the body that the patient's reporting pain, combined with an assessment of symptom severity. And this focused on three main symptoms of fatigue, of non-restorative sleep, and cognitive difficulties, as well as somatic symptoms, basically going through a review of symptoms and having a qualitative assessment of the degree to which those are positive, and then scoring to come up with a diagnosis. Now with pediatrics, back in 1985, Yunus and Massey first published proposed classification criteria based on a relatively small cohort of 30-some patients in their clinic, but they actually, even at this early stage, identified some clear features that have stood the test of time when it comes to amplified pain syndrome in kids, such as fibromyalgia. And of course, you need chronic pain, and you need to have ruled out other underlying causes for their pain with normal testing, and still at this time focusing on tender points. But if you see criteria such as chronic anxiety and stress, fatigue and poor sleep, other features such as headaches or irritable bowel symptoms that have also been validated and studied in adults. Now, if we go back to our first patient with widespread pain, with some GI features, with non-restorative sleep and chronic fatigue, she clearly fits a picture of juvenile fibromyalgia, or what we might also term diffuse amplified musculoskeletal pain syndrome. Now, more localized pain, such as complex regional pain, has more clear and well-defined Budapest criteria that involve both history of a patient reporting sensory symptoms, vasomotor changes such as skin color changes and swelling, and motor or movement difficulties. And on exam, we should be able to see such findings with allodynia or changes of the color temperature of the skin, like we saw in our second patient. And in adults, it tends to take a more significant physical injury trigger to cause this sort of pain, whereas in adults, it can be seen with more minor injury, and kids will be more likely to have a lower extremity injury as opposed to upper extremities, based likely just on the physics and their size, but more importantly, that they also have a greater psychological component. So they have more likely to have underlying chronic anxiety or depressive symptoms as predisposing factors for this. But reassuringly, they tend to have better outcomes than adults. And our second patient fits quite clearly with these autonomic changes, the dusky colored foot that she presented with. And we can move now to how I go about talking about pain with patients and families. We talk first about healthy pain that comes about in the setting of tissue damage or injury, and pain sensing nerves send those pain signals to the spinal cord and up to the brain, and the brain has to interpret those signals correctly. And when it does so, it can interpret mild pain as mild and severe pain as severe. And scientists have actually identified factors in the brain that can actually modulate the reception of those pain signals. So there are factors that promote those pain signals and factors that inhibit those pain signals. And in a healthy pain state, those are in balance and those are responding appropriately to different situations. But in the setting of amplified pain, we have real pain signals that are being sent in the absence of tissue damage. And over time, the brain comes to misinterpret those pain signals. And what we see clinically is that patients tend to have a shifting in their pain scale, and they're no longer really able to sense mild pain nearly as well. And so all pain tends to shift to a more moderate to severe end of the spectrum. And rather than the brain becoming sort of numb to these pain signals, blocking these pain signals, it actually becomes more sensitized to these pain signals. And those factors that actually promote or facilitate pain signal reception actually increase, and those inhibitory factors actually decrease. And this process of central sensitization is key to amplified pain and can be present in a variety of chronic pain states in both children and adults. And it really clearly shows that we as human beings, we've evolved well to deal with acute pain and blocking acute pain signals in moments needed for survival. But in the setting of chronic pain, we really have not evolved to deal well with that. And when we see pain signals that are sent in the absence of tissue damage, that can be evidence of peripheral sensitization as well. And the extent to which each of these is playing a role in a particular patient is not really delineated in a clinical setting, but both of these respond to the same forms of therapy. And when one part of our nervous system, the pain sensing part of the nervous system, is going haywire, we can also see dysfunction in other parts of our nervous system. You have the enteric nervous system of the gastrointestinal tract, and you can see symptoms of early satiety, changes in motility, diarrhea or constipation symptoms. And you can also have autonomic dysfunction, so tachycardia, lightheadedness, difficulty handling changes in position, as well as even temperature instability. Now, chronic pain is bigger than one particular specialty. And what we tend to see is that when patients come in presenting with joint pain, musculoskeletal pain, they might see orthopedics, they might see rheumatology at some point. But if they come in with abdominal pain as their presenting symptom chronically, they end up going to gastroenterology, reasonably so, and with headaches to the neurologist. But pain amplification can actually be seen in many of these pain states. And if we look at starting with chronic abdominal pain in kids, visceral hyperalgesia has been noted for quite some time in children with functional abdominal pain, and in multiple studies have been associated with a greater degree of underlying anxiety and depressive symptoms. And in the setting of headache, it's been estimated to be present in about a third of patients with pediatric migraine, and in adults with migraines is associated with greater degrees of anxiety and depressive symptoms. And also in adults with migraine has been associated with a decreased response across all medication categories in treating headaches. And so what this shows us is that the amplification of pain can occur in a variety of chronic pain states, and that it can really change outcomes in response to therapy in patients. And so simplifying this for patients and families, I discussed that amplified pain syndromes produce real pain that's present for the wrong reasons. And there can be challenges to evaluation and testing. It is in part a diagnosis of exclusion. There is no blood test or imaging test that can tell me with certainty that this is going on, but it's helpful when we see allodynia or hyperalgesia present on physical exam findings, because we know that some amount of pain amplification is present. It just may or may not be explaining all of the patient's pain at that time. But we need to be aware of incidental findings with testing, and we need to be careful with using pain as a proxy for tissue damage. So when we see tenderness on examination, we need to be careful with not necessarily assuming there's tissue damage there, and that can result in false positive exam findings. And as one example, this is a patient that I worked with, she was quite complex, but started out with a orthopedic surgery correction of a Madelung deformity in her right wrist, and was returning to her hand surgeon reporting pain chronically after her initial surgery. And each time on examination, he found a new area of pain for which he recommended surgery. And 6 surgeries later, her treatment team came to the realization that she actually has Munchausen. And even with extensive psychotherapy, was still continuing to have pain, symptoms of allodynia and color changes in her hand, and with some dystonic posturing. And she required quite a bit of therapy to get better, but she really didn't need to have 6 more surgeries on her hand. And patients and families often ask, well, why did this happen to me? Why did this happen to my child? And we know that stressors are triggers of amplified pain, and sometimes those take the form of inflammatory stressors, whether acute episodes of inflammation such as influenza or mononucleosis, or chronic inflammatory conditions such as juvenile arthritis, lupus, inflammatory bowel disease, as well as physical trauma, which, as noted for kids with CRPS, can be more mild injuries, but serious injuries as well can trigger amplified pain. And the largest contributor of stress triggers would be psychological in kids. And it comes in varied forms. And I think of them first sort of internally, what is going on in the patient? Is there underlying intrinsic sort of unhealthy levels of anxiety or depressive symptoms? Are they adjusting to a chronic disease, to inflammatory bowel disease, to type 1 diabetes, to a history of leukemia, for example? And then there are intrinsic factors. And with more time, we can identify more, and we can fill this slide with extrinsic factors such as extracurricular activities that might provide joy, but might also come with some amount of stress for patients, as well as if they're in an academically driven environment, if they've had adverse childhood events, which are known to be a chronic pain in adults, known to be an ACE-associated condition, including fibromyalgia. And then in the current COVID pandemic setting, I no longer ask of new patients, are you stressed? I ask, how are you dealing with stress? Not just because they're coming to pain clinic, but because the world globally is stressed at this time. And this has an impact now in the moment for people with chronic pain, and then also likely more people coming in with chronic pain later on. And when it comes to connections between stress and chronic pain, conversion is a great example of this. And conversion is a physical manifestation of an emotional stress. It's estimated to be present in about 30% of patients with pediatric amplified pain syndromes. It can take the form of motor, sensory, or cognitive symptoms. And I show you here one example of a patient with chronic widespread pain and severe anxiety, which I was having trouble getting her to really address more seriously. And she called our clinic one day reporting spacing out episodes. And she had just had a pretty extensive neurologic workup several months prior, so I had a low suspicion that we were missing something neurologic. But I asked her to keep a log of these and come back and at our next visit, and we would review these. And you can see here she did a great job of organizing this table here. But you can note a couple things. One, she didn't even note down weekends. And on days that she had no school, she wrote no school. She didn't write no episodes. And then you can see all the days in which she was in school and how many episodes of these spacing out she had. And I could look at this and go through it with her Socratically and come to a conclusion together about this association with schooling and why this was not something that needed to lead to MRIs or lumbar punctures at this point in time. Now, conversion behaviors can also take the form of conversion gaits, which intrinsically are inefficient. And you can see a shuffling gait in this patient, but when she's put on the treadmill and gently forced to walk more quickly, her body can't maintain that inefficient gait and more quickly becomes essentially near normal there. So why should we care about amplified pain syndromes? I'm not talking about brain tumors. I'm not talking about children in the intensive care unit, but in looking at long-term outcomes for these patients, we'll see the importance of why we need to be helping these patients. And this comes from a group at Cincinnati Children's that studied nearly 100 patients who were diagnosed with juvenile fibromyalgia in adolescence, and they brought them back as young adults. And they did medical and psychological evaluations on them. And they found that over half of these patients still met criteria for active juvenile fibromyalgia, despite previous access to a tertiary center. And they were pain-free, only 15% in this group. If we look at their psychological evaluations among patients with active or subclinical juvenile fibromyalgia, those patients, 60% of them were actually found to have moderate to severe anxiety. And over a quarter of these patients, moderate to severe depression. And although I don't have time to go into it, if you looked at other factors such as employment status, educational status, clear differences between them and healthy controls as well. So this is not just a pediatric condition, something that will go away on its own, but it's something that can really result in long-term changes in trajectory for a number of patients. So that brings us to treatment of pediatric amplified pain syndromes. And fundamental in working with anybody with chronic pain is trying to address all components of pain. So when somebody comes in and they say I have 8 out of 10 pain, 10 out of 10 pain, well, we start thinking of how many factors are present there. Are there mood symptoms that are contributing? Is there sleep disturbance going on? What sort of stressors are they facing, either in the home or among school or peers? physical conditioning, deconditioning that occurs over time starts to produce more of a myofascial component to their pain? And is there amplified pain present? Is there an inflammatory disease or other chronic disease that hasn't been identified and adequately treated yet? Or is there an injury that hasn't been allowed to heal? Likewise, are there dietary factors that may be contributing to their chronic pain? And all patients will come to us with some timeline of chronic pain, and pain will start, and they will start seeing providers and seeing some specialists. And eventually, if their pain doesn't get better, they see the pain specialist, right? But over time, what's going on is their function is actually also decreasing, and their stress is not surprisingly increasing. And where we meet these patients on this sort of timeline really can inform how we shape treatment and how we present treatment. And patients will often spend quite a bit of time, reasonably so, talking about this part of their story that involves determining whether there's an injury present, what's the extent of the injury, which involves testing, treatment, and more testing as subspecialists have seen and more treatments tried. And for those patients that respond, they don't need to come see us. For those that don't, they come to us with questions and say, well, how can we help now? And this part of the timeline certainly matters, but there's also the preceding part of the timeline. Where is this patient coming from? What was their life like prior to the onset of pain? And what sort of things are they losing because of pain? Are they athletic activities, dance activities, other extracurricular activities? Are they missing school over time? And to what degree are they isolated? Have they been self-isolating as they are less active, less social? Are they now changing or losing peer groups because they are no longer active in their particular sport or dance activity? And then how does this impact their trajectory in two ways? One is children at this time should be going through the process of figuring out who they are, trying identities, having peer groups as part of learning that process, and becoming more and more independent as they're on their way to becoming young adults. And when chronic pain sets in, it dramatically can change the trajectory of both these two areas of development. So goals for therapy. I'm a relentless optimist, and I'm very passionate about the work I do. And for me, I hope for a transformative process for patients with chronic pain. And we want to restore function, and we want to help them address emotional health. And we want them to learn healthy coping strategies for self-management of pain. And we ultimately want them to return to school and extracurricular activities if they choose to do so. But it's never something that I mandate. It just isn't something that I want pain to be a factor in terms of making that decision for patients. And perhaps most fundamentally, and something that I've been so fortunate to get more and more of an appreciation of in my nearly 7 years here at UCSF, is really reestablishing a healthy connection between the mind and the body. Part of this stages of development in adolescence is going through that period of getting to know your body, becoming more comfortable with who you are as a person, both emotionally and physically. And nothing can derail this like chronic pain. And so what we want is to reestablish healthy connections with these patients. And if they can do this, they're going to get ownership and independence. And that is the transformative process that we're looking for. So treatments for amplified pain are thankfully varied, and we have multiple options for working on this. And medications, unfortunately, I don't have much time to speak about today, and they're actually the smallest component of treating amplified pain syndromes in kids. And part of what makes that the smallest component is that there aren't very effective medications for treating amplified pain in kids. And what makes it difficult in terms of studying medication response and efficacy in patients is high placebo rates that are seen in chronic pain syndromes, both in kids and adults, well over 50%. And it makes it hard for studies to show efficacy of these medicines. But that's okay, because we have other options. And it begins in our pediatric pain management clinic, in which we're providing interdisciplinary care to relieve pain and suffering and to restore function in kids, regardless of whether there's amplified pain there or not, in a variety of chronic pain states and in a variety of degrees of medical complexity that we're fortunate to have the privilege of caring for as at Benioff Children's. Now, we have general pediatricians, we have integrative medicine specialists, we have an excellent pediatric anesthesiologist with Dr. Baruchi, and her expertise, and our psychologist, Dr. Benke, and licensed acupuncturists, traditional Chinese medicine providers, through a collaboration with the Osher Center for Integrative Medicine that has been transformative for us, for ourselves in our own clinic, and what we're able to provide, as well as massage therapy and expert integrative dietitian consultation as well, as part of our team. Now, shifting gears a little bit, trainees may have seen this photo before, but this was taken by Joe McNally, who's a National Geographic photographer. And often what I like to ask trainees is what they see in this photo. What are we noticing here? And what I see is someone who's got pretty extensive musculature on the right side of his upper body, with relative atrophy or smaller size on the left side of his body. And what really explains it is the fact that he's a fencer. And this is an Olympic fencer who has spent years training and refining his craft. And his body has adapted to that. And the body adapts to exercise at a cellular level, at the level of organs and fascia and other tissues, to produce profound changes in human beings. And this is not just for people who are quote unquote athletes. It is not for professionals, but for Olympic level athletes. It's for everyone. And so when people say, well, you don't have medicine for me, and I say, well, no, exercise is powerful. Exercise is medicine, and we're going to harness that power to both restore function and to treat pain. And that's where pain rehabilitation comes in, where we are restoring function and we're retraining nerves, these pain sensing nerves, and retraining the brain to reset its sort of pain thermostat, if you will. And we do this looking at fundamental domains of function, activities of daily living in the home, the school, and socially. But what makes pain rehabilitation from traditional rehabilitative therapies is that it's not limited my pain. We're not working with post-surgical patients. We're not working with patients with acute injuries. And we've concluded that patients are safe to exercise. But we also make it clear that pain relief is not the initial goal. First, we have to get that function back. And there may be some increase in pain, but we have ways to minimize that as well. And we need to remember that chronic pain is stressful. And so patients often have a cycle of pain that then leads to functional deficits, which then leads to physical deconditioning and pain-related fears of movement, fears of being in certain situations that in the past were easy to navigate and now in a chronic pain state are very stressful. So social outings with friends, you wouldn't think twice about going and walking in a mall or going to a park, but for somebody with chronic pain, those can be quite stressful to navigate. So the typical and reasonable human response is to just avoid those activities that cause distress and may worsen pain. But what we're trying to do is break this cycle in a healthy way. And so we're addressing pain-related fears and pain-based memories and helping patients learn to negotiate these efforts and activities over time. And we want patients to exercise despite pain. And we remind them that pain is not indicative of tissue damage. And we try to introduce movement in a minimally distressing way. And we want patients to modulate their activities to allow for proper recovery. So I often use an example of I don't want my patients to exercise so much on Monday that they're bedbound on Tuesday or Wednesday and can't get up until Wednesday or Thursday. And we also need to keep in mind this pain sensitized state and be ready for pain to change, for new areas of pain to come up, but to also be looking for potential injuries that can come up as well. Now, Ben Smith is a physical therapist and researcher in the UK who's written a great review about painful exercise and the evidence for it, and suggestions for how to make this safe and how physical therapists can work with these patients. And it really begins at, like any good provider, is understanding what does the patient understand? What are they thinking about their pain? How can we challenge unhelpful beliefs and give reminders that patients are safe to exercise? How can we enhance self-efficacy and help patients modulate this activity so that they don't overdo it, but that they're actually making progress? And that does often require expertise. And so outpatient of amplified pain syndromes, multidisciplinary, with in the most mild of cases, just giving permission to exercise, but often needing formal physical therapy, and psychotherapy that does not need to be with a pain psychologist, but it is a standard therapy for chronic pain. And although the greatest evidence is for cognitive behavioral therapies to be used, I often don't recommend that somebody look specifically for a CBT therapist, but it needs to be somebody that connects well with people at patient's age. And if they can't make that connection, then no amount of therapy is going to help. And if they're in a pre-contemplated, pre-CBT state, they may not be ready for CBT, and they might need to do some work before they get there. And we work on maintaining school function, and that may mean partial school days. That may mean a period of independent study, but we want to replace that school schedule with a healthy, activity-filled and consistent schedule so that patients are actually coming out of an independent study period having made progress rather than just having furthered their isolation and deconditioning. And we manage symptoms by validating them and by evaluating them when necessary, but providing reassurance when not. And we harness integrated modalities, whether that's in our clinic or locally to our patients who we see throughout California and beyond. So what outcomes are we looking at to assess patient response? One of the classic ones is a functional disability inventory, which has been well validated in the pediatric population, and looks at patient-reported difficulties in doing different activities in the home, at school, and looking at sleep as well. And we also look at other measures such as promise measures, which I imagine many in the audience are familiar with, that are more domain specific and can be applied and used across many different patient populations. And we're going to talk now about what we do when outpatient therapy is not enough. Well, it's our PAPER program. Again, not PAPER, PAPER. Pediatric Amplified Pain Rehabilitation Program. And intensive inpatient does not mean boot camp. A lot of people come to this with the notion of, oh, my kid's going to be in a boot camp. And day one is very different from one patient to the next. But what is fundamental is a lot of one-on-one time with our physical therapists, our occupational therapists, psychologists, and our creative arts therapists, with physicians and nurses playing a smaller role, but us looking out. What we're doing is looking out for injuries as they're going through their exercises, and they have time with our licensed acupuncturists as well, in coordination with the school teacher. Now, core team members for this endeavor, Dr. Christina Benke has been a partner from the beginning, and is a huge reason why our program has been successful. And I'm looking forward to working with her for a long time to come. Neha, Seth, and Andrea Ramirez are phenomenal PT and OT respectively, and have a passion for this work and working with patients with pain, and really strike that balance of respecting patients' pain, but helping them get the most out of themselves. And this program could not have gotten to where it's been today without their expertise and guidance. But in general, getting back to how we approach these patients, with few exceptions, we don't use medications for amplified pain. By and large, patients have tried them and they have failed. And we safely remove assistive devices such as crutches, canes, or wheelchairs. They get 6 days of therapy per week, and in pre-COVID times, they would get a therapeutic day pass on Sundays where they could spend 7 hours out of the hospital, really taking advantage of the gains in their function. And since that time, we've had to make changes in how we use that time efficiently. And only physicians are asking about pain explicitly, but other providers are encouraged to observe pain behaviors such as limp or other behaviors that tell us how patients are doing pain-wise. And we do ask, how are patients doing in general? How are they feeling? What is their mood like? But we're not focusing on pain explicitly. Parents can visit daily, but they are typically not present for therapies, and they're not allowed to stay overnight. And there's always a parent education component, and in some patients, parent and family therapy as well. So how do we create the space in which patients can heal? Consistency is important for replacing unhealthy or unhelpful habits with healthy ones. And it's not just a mental process, but I think about it physiologically and biologically as well when it comes to things like kinesiophobia, but also balancing patient safety with the need to help patients push through their limitations. And always coming from a place of empathy, really respecting their pain and remembering that we're asking patients to do difficult things. And we're focusing on restoring function, not on relieving pain. And principles of progression, what we're moving here is from one phase to the next, where from a functional standpoint, we're gradually getting patients to take more on in terms of more independence with their activities of daily living, and over time, more individualized interventions. And that can take the form of outings over time, school simulations, sports simulations. One patient who was an avid equestrian rider, we built out of different bolsters this sort of modified saddle and horse setup so that we could work on her stamina for riding. And psychologically, we're getting patients to move towards that ownership and independence and starting to plan their activities over time so that when they're ready for discharge, they've developed their exercise program for home, and they've developed a schedule and healthy habits for maintaining their function. And we do desensitization in our program in a minimally distressing way with varied sensory inputs, be they vibratory or different textures. And we also count on patients to start taking more of this on as their time in the program progresses. We also work on the fundamentals like balance and strength, and we often incorporate desensitization into those activities as well. Now, talking about candidacy for intensive pain rehab, we evaluate them, myself, Dr. Benke, and Neha or Andrea, and we want to make sure that pain is the actual cause of their disability. Are they safe for pain rehabilitation? Is there other testing that needs to be done where, yeah, they might be safe to walk around at home, but are they safe to be exercising 4 to 5 hours a day? And typical exclusions might be active eating disorder symptoms, suicidality, or severe profound depression. But things like joint hypermobility are not exclusionary factors for patients entering pain rehabilitation. Readiness also, we think about mentally. Have they accepted the pain diagnosis? Is there a willingness to exercise through pain? And in the mental health side, are they engaged in outpatient psychotherapy? If somebody hasn't realized the importance of psychotherapy as an outpatient and started a therapeutic relationship and learned how to speak with a provider, identifying their feelings and working through them, then they're not going to be able to work with several people one-on-one over the course of a paper admission. They should have some knowledge of and use of coping strategies, and their mental health should be in a state where we think they could really withstand the rigors of pain rehab. So evidence for pediatric pain rehab looks at outcomes such as the Bruce treadmill protocol, which was originally developed to assess cardiovascular stamina in an efficient way in adults. And over the course of 7 stages, every 3 minutes, the grade or the incline on the treadmill is increased, as is the speed on the treadmill. And this has also been studied in children with norms also established. We have validated traditional measures, rehab measures as well. And David Sherry, my mentor, first published outcomes data in pediatric CRPS in over 100 patients in 1999. And you could see the vast majority of those patients were functional within the first month, with 3/4 of them pain-free in the first month. And in follow-up of about half that group, about 88% of them were pain-free, although 10% of them did fail. This really was an outpatient program that was put together sort of ad hoc. Boston Children's in 2012, their Mayo Pediatric Pain Rehabilitation Center, which is another great pediatric pain rehab program that I've had the good fortune to visit and learn from. They published their outcomes showing significant improvement both in pain and disability in patients from admission to discharge in their program. And David Sherry published a 1-year outcome study in over 60 patients with juvenile fibromyalgia. And after completion of the program, they were brought back to CHOP for medical and psychological evaluations, including another Bruce treadmill test, which was wonderful that these kids actually signed up for the study. But we actually saw improvement. We saw them maintain their Bruce treadmill times by and large at that 1-year mark. And they actually maintained the gains they had made from their rehabilitative measures, as well as the improvement based on their functional disability inventory. And also reassuringly, we saw improvement in pain that was still maintained at 1 year. And their quality of life improved as well and was maintained. So moving now to talk to you about some discharge outcomes that we have for our patient, for our program that's been in existence for 5 years now. We've treated 29 patients thus far, and you can see their features here. The majority of these patients are female, most of them with diffuse pain. And the median length of stay was about 23 days. and all but 2 of the patients were able to complete our program successfully. And if we look at baseline promise measures, these are those domains that cross anxiety and other symptoms, and they're normalized. So you can see a T-score on the y-axis, and the greenish points are the patient's reports, and the red are parent reports. And here what we're seeing above the 50th percentile is unhealthy or abnormal levels of anxiety in our patients at baseline. And likewise, if we look at their depressive symptoms, also unhealthy levels and severe fatigue. And then pain interference, their pain, their disability due to pain itself, also at unhealthy abnormal levels. And their physical function well below the 50th percentile for the vast majority of these patients. And this is sort of the starting point. This is what where we start from. But we actually have shown dramatic and significant improvements in patients from admission to discharge. And what you're seeing here are the changes in patients from their admission levels of disability to their discharge. Again, this is a process that's going over about 3 weeks' time. And 15 of our patients were diagnosed with minimal levels of disability, with about 12 getting to moderate. And just as a reminder of the difficulty of this Bruce treadmill test and seeing how patients are able to really push themselves and improve their stamina over this 3-week time, with significant improvements as well. And often I get asked, well, what happens pain-wise? What's going to happen to my pain over this time? You know, only about a quarter of patients actually saw worsening of pain, and all but 2 of these patients that you can see on this plot actually completed our program successfully. So, and at worst, they had a 2-point increase in pain, but 3/4 of patients, their pain either stayed the same or got a little better in the setting of such hard work and regaining such function in so little time. Now, trends in mood symptoms. One of our concerns is, well, are we putting patients through too much? And reassuringly, we see that actually the trend is that patients' mood symptoms improve over the 3-week admission, outside of a few outliers that have much longer admissions and were more complex and had more challenging outcomes. But their depressive symptoms as well, the trend was towards improvement over time, despite the rigors of our program. And looking at our outcomes up to 12 months, with the caveat that, you know, we worked with patients from all over the state of California, from Hawaii, from Alaska, and those who get so much better are a little tougher to track down and are a little likely to fill out what I've been told on many occasions are rather extensive questionnaires. But I'd love to share with you what we have so far. And what we can see is sustained improvement in their FDI or their levels of function across time points. You can see on the x-axis, admission, discharge, 1-month follow-up, 3-month follow-up, and then a 12-month follow-up. And the trend really shows maintenance of this improvement. Pain is much more variable in terms of its level of improvement. The red crossbars here show means. And although these are statistically significant differences, I think we're losing some signal here in terms of our follow-up, and we may actually have more improvement in pain than what we think. But for many patients, this is still a chronic pain condition, but our goal is to get towards manageable pain that is not limiting them. And we also see sustained improvements in mood. So back to our first patient, it's our 17-year-old female with chronic widespread pain and gastroparesis requiring TPN. After working with her for some time, she came to me one clinic visit and she said, I don't want to go to college with a PICC line in my arm. I thought a reasonable desire for a high school senior to have. And so I talked to her about what a pain rehab admission would look like. And I said, you know, we can take the same approach with your GI symptoms, but you have to trust us on this and you have to be committed to doing this. And she was. And so what we did was we admitted her, and over the subsequent weeks, we established that she would be eating 5 small meals a day. And the meals is in quotation because for her, a meal was a graham cracker. And that's what she started with, and that was okay. That was a starting point she herself committed to. And we did not give medications for nausea. She had tried so many of them with no relief, so she didn't even want them. We established gradually increasing oral intake of water daily, and we were keeping track of calorie counts and weaning her TPN over time. And by day 21, we were able to discontinue her TPN and by day 28, we pulled her PICC line and she was discharged. And so this was the transformative process that I'm talking about. And this was a piñata that she made with our therapist, because she came to beat her pain in her TPN, and she certainly did. And on the left plot here, looking at her long-term outcomes, the triangular points are the data points for her paper admission. And you can see where she's maintained function up to a year later when she was still followed under our care. And then her pain went from a usual pain rating of around 4 or 5 down to 0 to 2 pain. And she had not, over that year's time, she had not skipped any meals. She had not had nausea that required ED presentations or nausea medicines. And so hopefully today, what we've talked about is amplified pain syndromes and showing you how they can usually have more than one trigger, how they almost always have a psychological component to them, which is inherent given that it's a chronic pain issue as well. And they can be associated with symptoms that span organ systems, span medical specialties, and why it's so important that we don't just work well in an interdisciplinary fashion in pain management clinic, but great coordination and communication with our clinicians in other specialties at UCSF and in the community. They can be debilitating, and they don't require medication, but medication can be sometimes helpful. But they do require multidisciplinary care, and patients can often get better in an outpatient setting. But for those that need intensive pain rehabilitation, they can be treated safely and effectively. But that requires a team approach, and that's why I'm fortunate to work with general pediatricians, the physiatry team, the rehab team, and our creative arts therapists and our child life therapists. And I'm very happy to answer any questions. Thank you very much for your attention today.
Thank you so much, William. This was really fantastic. We have a couple of questions that are actually about the same topic, and I see one hands up, but perhaps the person who has a hands up can put the questions in the Q&A box. So the two questions are actually essentially about the same topic, and they're about children who have, and young adults who have sickle cell patients that oftentimes come to the ED for, and are admitted for pain a lot. So do you have a specific approach to patients with who have a specific cause of their pain, such as sickle cell disease? And how can we get these young individuals into these service, hooked up with these service earlier?
Thank you. That's an excellent question. And one of our goals moving forward is to actually be able to broaden our pain rehabilitation approach. Not that we expect everyone to be able to do 5 hours of exercise therapy a day, but that we really personalize it to the patient's underlying medical state. And so this functional approach can be taken in in patients with quite a bit of medical complexity. And in the case of sickle cell disease, for example, would require very close communication with the hematology team so that we had an assessment of, okay, what's going on pain-wise here, and what do we need to do to make sure that we're not putting the patient at risk. But it's certainly something where our pain rehab program, in terms of an intensive inpatient fashion, is not set up to work with patients with sickle cell disease. But I think it's certainly a patient population that would be amenable for a more still comprehensive, still interdisciplinary, but more of an outpatient approach, where rather than compressing rehab into a very intensive timeline of 3 weeks, but really spreading it out over time. And it would look different than a typical sort of, hey, here's your 6-week course of PT for a sprain or a strain.
Thank you. I do not see any further questions in the box, so I'm going to hand it back over to Dr. Hirsch for concluding comments.
Thank you.
Well, thanks. I want to thank, first of all, Will Bernal for a fantastic grand rounds, and also again to Marsha Treadwell for her very powerful introductory remarks. And I would like to wish everybody a good rest of the day. So, Sandrain, did you want to make an announcement about the next grand rounds at all?
Yeah, we have just a couple more grand round sessions coming up, and I actually I just noticed that there is a question. Elliot mentioned to ask his question on the Q&A. So, Will, if you have time to just hang on for a few more minutes at the end of this, then we'll answer those questions.
Happy to do so.
Before we send everybody who needs to go, of course, needs to go. We do have, I think, if I count correctly, 2 or 3 more grand round sessions, 3 more actually. And next week we have residents presenting on their QI work under leadership of John Takayama. And then on June 18th, we actually have a parent's perspective on child's long chronic child disease. So that promises a very interesting topic. And then we end the year with a session on the innovative ways in which our educators in the Department of Pediatrics have dealt with the COVID-19 pandemic, with some great presentations by students, residents, fellows, and faculty. So those are the next 3, and then we're taking a break for the summer. So for all of you who have to go, I will let you go, but we'll stay around for just a couple of minutes to answer a couple more questions. Thank you all for you who could make it today. Well, there's a question from Elliot Vincinki about opioid hyperenergesia, which is something seen apparently in sickle cell. Do you have any comments on that?
Yeah, so the opioid hyperalgesia is something I'm not an expert in, but I'll say that works through different mechanisms and can still, that certainly is an area where other medications and things like opioid rotation and other adjunctive medicines can decrease that. But particularly what you can see in patients that require long-term opioids or can require, like in the sickle cell patient population, is that one goal of a functional approach would be to minimize the need for exposure for opioids so that we can minimize the risk of opioid hyperalgesia.
Thank you. And then the last question is actually from one of my colleagues in critical care who practices mainly at the Oakland campus, Dr. Mandeep Chadha. He's asking, you discussed the overlap between amplified pain syndrome and somatoform and factitious disorders. And in the inpatient setting, it can be hard to maintain focus and compassion for these patients when we suspect somatoform disorder. And then finding a balance between treating pain and ongoing diagnostic workup is challenging. I don't know if you have any comments on that per se. He's also asking whether you're available for consultation.
I'll be careful with the answer to that question, but in all seriousness, I'm more than happy to help and provide any insight. In working with our IP3 colleagues as well on that side of the Bay who do quite a lot of work. That is it's a fascinating question to me, sort of intellectually and clinically, but I can tell you one of the shifts that's really challenging for providers to help patients and families make is when somebody comes in with acute symptoms, severe symptoms, and needs an urgent medical workup, gets admitted from the emergency department, for example, and gets expedited workup for good reasons given the severity of the symptoms. And then when things are found to be normal, to not have a tissue damaging sort of cause for their symptoms, then trying to shift to, okay, these symptoms are severe and you're suffering, but more testing and more medicalization is not going to help with that. But it's human nature to want the simpler or easier approach, whether it's another medication or a particular procedure. But as providers, we need to be careful with our biases, right? So our biases are towards what our expertise is in. So as a rheumatologist, half my job is better living through chemistry. And as a pain doctor, half my job is convincing patients to see a therapist, to work with a therapist, and to talk about things that are hard to talk about. And in the hospital setting, everything is biased towards doing more, doing it efficiently, still doing it safely, but what are we subjecting our patients to, and what sort of message are we giving them when we have medicalization as a consequence of what we do? And one of the things that makes me proud to be at UCSF is seeing how deftly our pediatric hospitalist colleagues really manage that. And that really begins with rapport and with establishing trust. And in acute settings of an emergency department or of an ICU, that can be harder to do. That has to be compressed, and there's a shorter opportunity to do that. But sort of that process of repeatedly taking people through what's our thought process, lots of testing, very reassuring results, but still severe symptoms, and what are we going to do about that? And having this handoff to pain management. One of the things that IP3, our integrated pediatric pain and palliative care service, has been doing for several years now is really optimizing that transition from inpatient to outpatient, so that we improve the quality of care that we're providing, and so that we minimize the stress that this causes to patients and families, and also to our coworkers, because just like I wouldn't expect a diabetic patient to be treated in rheumatology clinic, I can't expect somebody with these severe symptoms that might be an amplified pain process to get the right treatment in an ICU or necessarily inpatient setting. And so what we do is really establish rapport, but we don't start treatment immediately. We sort of bridge them to an outpatient basis, and whatever we can do and troubleshoot with Mandeep and others to sort of continue to work on that process would be great.
Thank you very much. I think that leaves us with no further questions for now. I'm sure other things will come up and people know where to find you. So thank you so much for a fantastic presentation. And with that, I will end this Zoom webinar, and I wish everybody a good rest of their day.